Welcome to Third Floor Views, a production of Chesapeake Family Life, where we talk about health, education, and living with kids. I'm your host, Janet Jefferson. Today, we are discussing what to do about going back to school. And we have some pediatricians here to give us their perspective. So we have Dr. Margaret Turner, who is a pediatrician from Annapolis Pediatrics. And we have Dr. Erin Millstone, Associate Hospital Epidemiologist at Johns Hopkins and Professor of Pediatrics. So big thank you to both of you for being here today, because I know it's a crazy time and I know how busy you are. So thank you, thank you, thank you. To our viewers, please feel free to put any questions in the comments section, and we will get to as many of those as we can. Let's get started. So the big question right now on everyone's mind is, should schools open this fall, and is it safe? So let's break that down a little bit. I also want to acknowledge that we're going to focus mainly on children, because that's your expertise, and not teachers. And so acknowledging that this is only part of the equation, because adults are a whole different bag of worms here. So let's explore this idea of going back to school. Would you send your kids yourself as a doctor and as a parent? And what would it take for you to feel comfortable sending your children? So let's start with Dr. Turner. How do you feel about sending children back to school?
I feel very strongly that kids need to be in school. It's really, really important for their developmental growth, for their social emotional growth, and for their academic growth. So I have a 16-year-old who I'm very, very hopeful will be back in person learning in the fall, as well as two college kids. That is a whole nother challenge. But speaking about schools in general, there's a lot of challenges to getting them back in safely. So it's a caveated, yes, I very much want them back in if they can meet certain criteria.
What about you, Dr. Millstone? How do you feel about children returning to school?
Great. I didn't realize we're going to get a good pro-con here today, I think.
Well, I want to break it down too and have both of you talk about sort of what would it take? Like, what are the things that would make you feel comfortable? What are the things that you would have to see in place for us to actually return to school? So what do you think, Dr. Millstone?
Yeah, I agree with what's that? Can you hear me?
Yeah, we're hearing you just a little bit. Here, Dr. Turner, how about Dr. Turner, if you could just speak to us a little bit about what are the things in place that you would like to see to get those kids back in?
I think they need to be universally masked. I think that's, should not be controversial, but I think there's a lot of controversy surrounding it. I think the kids have to be in masks when they're in transit, when they're moving around. I think there has to be cohorting of classrooms. I think there can't be the spread of different kids in different classes all the time. I think they have to be much more cohorted in order to minimize risk, minimize exposures, and being able to shut down small groups if there is any positive cases. I think the distancing piece gets more important the older they are. So, and we'll wait for Dr. Millstone to come back because he has a lot more data on that. But I do think when you look at distancing, the younger kids probably don't need a full 6 feet, whereas the older kids certainly do. So I look at all of this as being such a hyper-local process, as well as a age-based process, that what's going to be good for lower schools and elementary schools is not going to be the same criteria for upper schools and high schools.
Right, absolutely. Yeah, you'll see different needs for different kids and different ages. Definitely.
Sorry about that. My internet in my office is often sluggish. That's why I try to call.
Gotcha.
I was just agreeing with Dr. Turner about our desire to send our kids back to school. I think what's incredibly important right now for parents to think about is that this is a dynamic, changing situation. And what we see today may look very different in a week, 2 weeks, or 4 weeks. So I think for parents to be preparing for options, their kids either going back to school or not going back to school, recognizing that they need to be flexible as the landscape, as you've seen in other states, and we've even seen our own state changes quickly. So I think that's important. I think Dr. Turner also mentioned some important things of what we would want for our kids to go back to school. I think in ensuring that kids are staying home if they're sick. I think ensuring that kids are masking. There are lots of things that we see going on out there that make me suspicious that parents are willing to adhere to those principles right now. There are lots of teenagers who are congregating at parties in athletic competitions. They're getting sick. I'm sure Dr. Turner has seen many kids, an increasingly number of kids with COVID. Those kids will put their classmates at risk and their teachers at risk. So it's not just about what's happening inside the school that's important. It's equally important in what's happening outside the school. So these social contracts that, yes, if my kid's going to go back to school, I have to know that what they do on Friday night is going to put everyone at Monday, or on Monday will put everyone in that classroom at risk. So I do think that although we want our kids to be in school, there still are a lot of things that need to be put in place for that to happen safely.
Let's talk about that a little bit in terms of school environment and some of those details. So we have a listener who asked a question on masks versus face shields and things like that. Does that make a difference? Do we need to see one versus the other? And are you noticing, or at least with your academic journals, are you seeing one be more effective than the other? Dr. Turner, go ahead with that.
I would let Dr. Millstone answer that. My understanding is that masks are far superior to just masks to the face shields alone, but I would ask your opinion on that.
Sure. So I mean, masks are great cough catchers, right? You wear them and they're really protecting everyone else when you cough because they catch those small and large droplets that come out of your mouth. So the masks are really protecting everyone else from you. Shields do similar things. A shield is a barrier that will also catch or try to block those droplets as they come out. But shields, unfortunately, are not as good about, if you turn your head a little, they're not as good about catching things that may go under and or around. So I know there's been interest in shields because some people find them easier to use, especially in settings where with people that have trouble breathing or feel uncomfortable in a mask. But there now are lots of different types of masks. And masks, we're not going to have a head-to-head scientific trial to prove this one way or another. But I think most of us feel that the masks are probably safer. And one thing for parents to be thinking about, I'm sure Dr. Turner tells her patients this, is that masks are like behaviors for kids. Kids, the first time they wear them, they're not going to like them. They're going to be different. They're going to think they look funny or maybe the first couple of times they think they're fun, and then they might not want to. So as parents are preparing for the fall, thinking of this as practice, and how can I get my kids to practice wearing a mask so it becomes something that they're a little more comfortable with and accustomed to. So if they get into that situation where they're in a classroom for 6 hours, they're going to be comfortable wearing it that whole time, not playing with it, touching it, fidgeting with it.
Right. Yeah.
I've been amazed actually because we have a universal masking policy in our office. So every kid over the age of 2 basically comes in with a mask. And I have to remind the kids when I say, oh, okay, let's open your mouth so I can look. They open their mouth with their mask on. Oh. And I have to say, okay, remove your mask so I can look in your mouth. They become so accustomed to having it that they really tolerate it better than the parents do, quite frankly. We are not finding kids walk in the room and immediately rip the mask off. They're very respectful with it. They really are quite good at it. So I do think it is a learned behavior. And if you teach kids how to do things, they do a pretty good job. It is sort of amazing. I think kids with sensory issues and kids that have some developmental concerns, there may be some kids that can't, but there's very, very few kids that can't tolerate a mask. So I'm a big believer in masking everyone.
That makes a lot of sense. What are some of the biggest vectors that you would be concerned about in a school? So thinking about building circulation, like ventilation, shared hallways, shared bathrooms, cafeterias, meal times, shared resources, both materials, but then also shared teachers. What do you think some of the biggest vectors might be? Dr. Millstone, what do you think about that?
What we've seen really is the highest risk area probably might be meal times because it's a setting where kids are having to take their mask off. These aren't just kids; these are anyone. This could be teachers in their lunchroom. When you go into an environment where you take off your mask and you're not able necessarily to sit distance from each other, and people are talking when they eat, and we've all seen people when they eat and they talk at the same time, stuff goes flying.
Right.
So those particles are going to contaminate other people's food. They could contaminate, right into people's respiratory tracts. So meals are going to be a big challenge for schools, because that's the one time where we know that people will be having their masks off by necessity. So trying to think about how kids can stay at a distance when they're eating. I mean, this is not, we're asking kids to not behave in their normal comfort zone, right? Like kids like to be together. They like to touch, they like to be physical, they like to be interactive and intimate. And we're going to ask them to sit and have lunch 6 feet away from everyone. So that is a setting that will especially create problems.
Let's talk about safe numbers. We've heard that 10 is sort of the magic number. Dr. Turner, do you agree with that in terms of number of kids back in classroom? Are we looking at smaller class sizes, or does it depend on the size of the room? Does it depend, 6 feet versus 3 feet, mass or not? What are all of those different pieces to think about what's a safe number?
I do think it depends on the size of the room.
Okay.
And because you are looking to have some distancing. And, so we were on a webinar from Children's not too long ago where they talked about the younger kids, because their transmission, sort of how far particles go flying is a little bit less than an adult. Probably in a smaller, they can have a smaller 3 feet versus 6 feet. I don't know that that's been proven per se, but I think when schools are looking at opening, I think smaller numbers of kids is always going to be better, but they're going to be limited by how many rooms they have. I think the idea that you could try to put the desks apart and try to keep them apart. I've seen some things that talk about putting it in a circle instead of stacked up next to each other. You'd have less crossover that way. So I do think it's all about the size of the room, the number of kids, the age of the kids that are going to be in that room. Kids do need to move. They need to be up moving around. So I think it isn't just about 6 feet. They have to be able to get up and move. You can't ask a 6-year-old to sit still for 6 hours and not move. So I think it's also going to be looking at utilizing outside spaces. Kids are going to need more recess. They're going to need more time up and moving around. They're likely going to need some mask breaks. I don't know many doctors that don't come out of a room and immediately take it off for a second and then put it back on. I don't think we can ask 6, 7, 8-year-olds to sit quietly in a room, not moving at their desk. So you are going to need a lot of space.
Yeah, that more resource is a really important point. I think that's one of the things that parents have been wondering, and teachers too, is this, like, do we need to send kids outside more for a lot of reasons, for safety, but also for being able to get those wiggles out, because they have to sort of follow more strict rules. So developmentally thinking about their needs as well. So I think that's a good point. Let's talk a little bit about what if someone is diagnosed with COVID-19 in a school. What does that mean then for everybody else? So Dr. Millstone, let's say you have a positive case. What does that mean? Does the whole school need to shut down? Just the class? Who needs to then not come to school?
That's a great question, and I'm sure that's one on many parents' minds. I usually kind of walk this backwards, right? So right now, what we're being advised from the CDC is that the highest risk of getting the infection after exposure to someone is if you were within 6 feet for more than 15 minutes. So you can imagine a classroom setting where you have children that are all spaced apart 6 feet. That would be great, because that would limit your risk, especially if we can increase ventilation in the rooms. Because again, most of these infections or these transmissions are occurring by large and small droplets. And these are things that when you cough, they drop out of the air within 6 feet. So if kids are outside of that 6-foot zone, then it will protect them, or it's a way to help protect them from exposure. Now, with that said, you can imagine a classroom, as you were saying, kids are dynamic. They like to get up, they like to move around, they go to the bathroom, they go to the board, they do all kinds of stuff. So I think parents should be asking themselves, and administrators ask themselves, a couple of questions. So if I have a child in a classroom who is sick, can I confidently say to a parent that your child was not within that window of 6 feet for 15, and we say cumulative. So it's not, oh, I was 10 minutes, I walked away, I came back for 10 more. We say kind of cumulative 15 feet for 6 feet for 15 minutes. So I think a lot of people will question that. So there's not going to be a, yes, we think your kid is at the highest risk, but it could be your child was in a classroom. So my anticipation is, because no one's going to be able to really identify where kids were sitting and how much they were moving around, this will happen at within pods or units, where if a child in a classroom is identified as sick, then that class may be deemed exposed. Now, these decisions are not determined yet for sure, and they'll be informed by the health department, I'm sure, with wherever the school is, and any consulting physicians that work with those schools. But likely, if it's a child in a classroom, it will be that class. And not only will it be that class, but then it may be that teacher. So I think, although everyone's optimistic about people going back to school, you have to start thinking backwards of when there is a child that is sick, which there will be, then there's a class that may then entirely get sent home for 2 weeks. And if the classes are mixing, like I'm in a math class during this period, and then I switch to a different classroom for a different period with other students, it could amplify pretty quickly. So I know that schools and administrators are thinking about this and how can they kind of cohort classes together to kind of limit the amount of movement around. But then, as you mentioned, there are these other opportunities for exposure that are a little harder. So what about lunchtime? What about recess? What about, again, you still hear people talking about sports at school. How are you going to decide who in a team or within a gym class were exposed? So it's possible that one child, one illness could lead to exposing a lot of other kids. And there are things we still don't know about this virus. And then there's everyone's anxiety about it. So all the parents that are going to hear, a child in my kid's school was sick, what does that mean for my child? So I do think that as people are projecting ahead to the fall, really thinking about what it might mean for your family and how your family will respond to those notifications. Are you going to be comfortable sending your kid back to school? Are you prepared for your kid getting sent home from 2 weeks, which, as we all know from the spring, is very difficult? Staying home from work, working from home, trying to balance that. I think people really need to be prepared, because even if schools open, there will be situations where kids will be sent home and people will have to be prepared. The schools have to be prepared from a mixed method of learning with, a hybrid online, in person, but parents have to be prepared for that as well. So I think that flexibility and early preparedness for these different possibilities for fall is really critical.
Yeah, there's a lot of pieces to consider. I want to shift just a little bit and focus on actually the disease and kids and how it presents in kids, and some of the issues that you see with COVID-19 in children opposed to maybe adults. So I also want to bring up a recent article that has been circulating that I think has a lot of parents, a little concerned. So I want to talk about how often kids actually get COVID-19. Originally, we were hearing things that they were less likely to get COVID-19. An article in The Hill stated that 30% of children tested down in Florida tested positive for COVID-19, and that came out yesterday, and that sounds really alarming. But what's the story? Are kids getting COVID more than adults, less than adults? What do we need to be worried about with our kids? Dr. Turner, do you want to start with that and just to speak maybe a little bit to that Hill article?
So, we've been open since all of this happened. We did not close at any point. So I do feel like we've sort of watched Maryland evolve with 35,000 patients. We have had only a handful of kids actually be positive, and almost every single one of them up until the last little bit, where we're seeing older kids being out with friends getting exposed. Almost every kid we've had has gotten it from their parents. So even kids that have been in daycare, we're not seeing a lot of transmission amongst kids. It is really fascinating to see now all these 19-year-olds, 20-year-olds, 22-year-olds. A lot of them are starting to be positive in these groupings of 5 of us went out on a boat and now we all have COVID. Some of them know where they get it, some of them don't, but lots of teenagery kids over the past weeks. but everybody else that we've seen really a lot of barbecue transmission. So we had a July 4th barbecue, and now my 4-year-old can't smell. So we've really had very, very few positives. Of all the kids we've tested, we have very few positives, which is miraculous and we're very excited about, but they have been pretty well quarantined. So I do think it's going to, based on as kids start to be out and about more, we'll see if there's more positivity rates in kids. But right now it has been strangely quiet, that it's really been more the adults than the kids.
Gotcha. Are you seeing the same thing, Dr. Millstone? Are you, what do you think of these numbers down in Florida? Does it look like children are equally diagnosed with COVID, less likely to get COVID, more likely to get COVID than adults? What are you seeing?
Some of the data are hard to interpret because, as Dr. Turner knows, early on in the pandemic, it was discouraged from testing kids because they really wanted to save testing for frontline providers, healthcare workers, elderly, like what were considered high-risk groups for disease. So now that we have increased testing, I think we will begin to see more in pediatrics. And again, like Dr. Turner said, a lot of the teens and 20s that are seen in pediatrics have not the same symptoms as the adult. They're not coming to the hospital with respiratory failure. Most of them, I mean, we had deaths in teenagers and young kids. So this isn't a disease that doesn't affect pediatrics. It just doesn't seem to affect kids in the same way. Doesn't mean that kids aren't carrying the disease and transmitting the disease. They may just not have the same symptoms that adults do and don't get recognized, brought to medical care, and tested. And I do agree with Dr. Turner. I don't think we're really going to know that until kids come out of quarantine. And when I say quarantine, shutting down schools had a huge impact. Now they are, even when there are day camps, the camps are outdoors, they're distanced. It does not in any way simulate a school setting. So once we put kids indoors in a dense environment, we really don't know what that's going to look like. So I think there's more to learn. And I would point out, what we have been hearing more about, and I'd be curious what Dr. Turner's hearing down in Annapolis, is we are hearing more of exposures in daycare settings. So daycares are starting to open up. We're getting reports of kids being reported in daycare centers. And then we had someone within our system whose child was in a daycare center, reports from that daycare center, and now parents are positive. So that was something that came up through the daycare, not parents bringing it back to the kids. But I do think Dr. Turner's observations are completely dead on, which is early on, the parents were out, the parents were the ones that were working, getting exposed, bringing it home. And that may change as kids go out and start mixing more and then bringing it back to their families. I think we'll have to see.
So it sounds like we just don't have a lot of data, and that we just don't know exactly what to expect because we haven't had kids in school, especially in winter time when we're going to be potentially more inside in these enclosed environments. So it sounds like it's hard to make some of these calls because the data is just not there. We just haven't experienced it. I think that's really hard.
Hard in kids actually is that the symptoms of COVID look like the symptoms of every other respiratory illness. So we actually have lots of kids getting sent home for colds and coughs and fevers that actually are testing negative, but they're being listed sort of as a COVID exposure, a possible COVID exposure, sometimes to the point of shutting down an entire daycare because of a fever. One kid with fever goes home, and until they are proven negative. So I think that's what we're most worried about for the fall and winter, is that normal kid viruses are still floating around, and viruses that are very serious in kids, RSV and flu. And we really desperately want all of our kids to get flu shots this year. We really think it's important because, we don't know what flu and COVID looks like together. We don't know what's going to happen when all the other viruses, because that's the other piece, that right now it's summer. This is our slowest time for viruses normally. So when the fall and winter ratchet back up, we're very concerned. Every kid with cough, congestion, cold, fever is a potential COVID kid. And do we have the testing in place? Is the testing good enough to really help delineate who is a risk and who's not? And does universal masking actually help decrease some of the normal viral transmission? It's entirely possible we'll see a lesser flu season if everyone's wearing a mask and is not coughing on each other. Maybe it'll have the added benefit of shutting down a lot of congestion, cough, fever viruses. So
I just want to reiterate, that was a great point you made about what to expect this fall and winter, because unlike in the past where the school policies often were reliant on fever. If your child has a fever, they can't come to school. Many kids would go to school in September with allergies, with coughs, runny nose, other URI, upper respiratory tract infection symptoms that didn't have a fever associated. This year, we can't really afford that because those are kids that might have COVID. So if your child has any of those symptoms, they'll be recommended to get tested. And currently still, the test turnaround time is, Dr. Turner, what would you say? You're sending patients for testing. What are you seeing down there to turn around?
5 to 7 days is pretty average.
Right. So if a kid has a cough and they get sent home for just testing and they're home for 5 to 7 days, that's much different for families than what they're used to, which is I give my kid a neb because they have asthma and I send them right back to school. So again, I think the fall will look very different than it did last year, even if there is in-person education. So I want to again remind parents that they have to prepare for the fall to look very different.
We're talking a lot about a simultaneous hybrid model of a virtual and an in-person, because if you have to come home for 5 days every time you get a test, you can't miss school, and even the current CDC guidelines. If you are positive, you're 72 hours after your last fever, 7 days from the end of symptoms, you're looking at 10 to 12 days for a positive COVID kid. They can't necessarily be out of school for 12 days out of before you know it, a kid has missed half of a quarter. That's too much education to be missing. So there really does need to be a simultaneous virtual option and if there's enough kids in a school and the school shuts down for 2 weeks, there has to be a seamless transition between in-person and out-person. And I don't know that the schools are prepared for that at this point. And I think that is another consideration when we're looking at opening. As much as we want them to be open, there does have to be this go back and forth between virtual and online.
Right. Let's take a last.
Can I add
Go ahead,
one more
Dr.
thing to that?
Millstone. Yeah,
Another
absolutely.
thing that for parents to think about is if your child comes home with COVID, you are a household contact of a COVID patient. So you are home for 14 days. So for parents that, go to work and rely on going to work or need enough that they can't work at home, if your child goes to school and gets sick, then you are home for 2 weeks.
Yeah, that's definitely something to consider is the ripple effect. So in the last couple minutes, I just want to talk a little bit about social implications and emotional implications for students. I know the American Academy of Pediatrics had come out saying that is a big concern right now for students. But let's say we do send kids back to school and they have to wear masks, be socially distanced. They're not going to have the same environment that they were returning to before. Is school going to provide the needed social, emotional sort of aspects that we are thinking of when we think of, oh, return to school, it's going to be normal just like it used to be, but it's not. So how does that balance out, and what do you think about when you're thinking about pediatrics and cognitive and emotional development? What are some of the things that you think about when you're putting kids in this new school environment? Dr. Turner, why don't you start with that?
I think something is better than nothing at all times. So yes, it's going to be different. And I think preparing kids for the fact that it's going to be different and working on that over the summer is a big piece of what we've been doing in my own home with my 3 who are all going to go back to something different next year. It's a lot of how do you make the best of what you can have, and how do you protect yourself the most and protect people around you the most while still gaining some of the benefits. So I think in-person learning is at this current juncture in time is clearly superior. So in-person learning, socially distanced, wearing a mask is far superior to virtual learning at home. The just being in a classroom with other kids, seeing your friends, even if you're not able to sit and eat at lunch the way you normally would, I think, there are definitely kids who are social anxious kids that are perfectly happy to stay home and never go back and see another person. That's gonna be a whole nother problem we'll deal with when they go back. But at the same time, I think being with other kids, being around other people, that's really good for developing social skills and avoiding social anxieties. The longer you stay away from people, the harder it gets to re-engage.
Gotcha.
So I think something's better than nothing is sort of the way we're approaching it, but with safety in mind. So safety and access they're dual pillars, and they both have to be met in order to have success.
Gotcha. Dr. Millstone, what do you think about making sure that kids, especially young kids, I'm thinking about young development and always having a mask on, is that going to hinder development at all for these really, really young kids? And does that negate some of that social emotional aspects of being in school? Or do you still think it's worthwhile, even though for those really little ones? I'm thinking like preschoolers specifically.
When you say development, I'm not sure exactly what you mean. I mean, if what you're asking is, we learn a lot, and I think Dr. Turner was alluding to this, we learn a lot from social cues from people.
Exactly. Yeah, watching someone's face,
right.
learning emotions.
Right. I mean, it's probably the same struggle we have of using Zoom. I mean, even on Zoom, it's much harder to capture people's body language. It's harder to capture some kind of subtle expressions that people have. I mean, we all talk about this on Zoom. It's just not the same interaction. It's still nice to see people, but it's not the same. So I do think kids will miss some of that that learning from that social interaction for sure. I mean, there's no doubt that'll happen. So with that said, and what I've been encouraging parents is, we live in a society right now that's very innovative and likes thinking outside the box and being creative. So I mean, this is going to be a time where people have to think of how they can support their kids in getting what they're missing in school through other means. So it's really a time where, I mean, we've been amazed, like, wow, we actually have family dinners again, right? So where we used to be running around and doing activities every night, we now get to sit and have conversation and talk. And I think thinking about how you can engage kids, even with adult conversation, to hear stories, learn from sibling dynamics or other family dynamics. So yes, I think we have a lot to learn about the negative impacts of this pandemic for sure. And as Dr. Turner mentioned, it's really going to be a fine balance between physical health and social and emotional well-being. And we have to try to optimize both of those.
Mm-hmm. Absolutely. Well, thank you so much to both of you for being here today. So to Dr. Turner and Dr. Millstone for taking the time to answer some of our questions, our many, many questions about what to do in the next few months. And then as this is a changing topic, as we're learning more, how that unfolds. So thank you. Thank you to also all of our viewers and listeners today. Make sure to visit ChesapeakeFamily.com for any up-to-date local information on health, home, and parenting for today's Maryland parent. This episode will be archived on ChesapeakeFamily.com. I'm Janet Jefferson with Chesapeake Family Life. Thanks so much.
Thank you.
Thank you.